Hello, and welcome to EVRMA's fourth live online journal club. For those of you who have been at our previous events, welcome back. If it's your first time with us, welcome. We hope you really enjoy this journal club. In today's journal club, we're going to be discussing recurrent implantation failure. First, we're going to have an introduction by Richard Scott, followed by the presentation of two very interesting papers by Paul Purtea and Mauro Cozzolino. And then we will end with a discussion involving all of our panelists. As always, we're going to be taking questions from the audience, from you. So please send them in through the little Q&A button on the bottom of your screen, and we will address them during the discussion as we go. As we do with all of our journal clubs, this one is also going to be available through our FertiliPod podcast, and the video is also going to be on our website at ev-rmainnovation.com. Our first speaker is Dr. Scott, who is one of the co-founders of EVRMA Global, as well as professor at Thomas Jefferson University and Rutgers University, and the Reproductive Endocrinology and Infertility Fellowship Director at RMA New Jersey. Dr. Scott, welcome. The floor is yours.
Thank you very much. Really appreciate the opportunity. I'm very excited for today's podcast and to have an opportunity to listen to the reviews, presentation of these papers and the reviews by a variety of experts for where they fit into our literature and how they're impacting our understanding of patient care and management and our biology and the biology of the system. Recurrent implantation failure has been an important topic in clinical reproductive endocrinology from the very beginnings of IVF. In the mid-1980s, when I began my reproductive endocrine fellowship, there was not a formal definition for recurrent implantation failure. And from a professional society standard, organizational standard, WHO, there's still no absolute standardized definition. But the widely used definition in those days was 4 transfers of 4 embryos each. So if 16 embryos failed to implant and sustain development, that was considered recurrent implantation failure. If someone had failed 3 transfers of 4 embryos and had 12 embryos fail, that was not recurrent implantation failure. And over time, as we ask those questions, the definition and the evaluation process has evolved. In the beginning, even though we didn't really know that much about embryology, and certainly things were not optimized, everyone still looked to the endometrium. If you had a morphologically normal embryo and it didn't make a baby, it's got to be the doggone implantation process on the endometrial side. And so Jairo Garcia, many others, did endometrial biopsies and talked about endometrial advancement and endometrial delay and timing, which of course the group at UNC has shown is probably not the most accurate way of doing things, but those studies, Murray study, had not been done. So the reality is everyone kept looking to the endometrium. And yet as the history has evolved and the number of embryos that might be required to consider recurrent implantation failure a factor has diminished, of course, most of the changes have been on the embryonic side. We're still fundamentally managing the endometrium the way we always have with estrogen and progesterone and some basic understanding of the window of implantation, which hasn't changed that much since DeVote's early work in the early 1990s. And so by the mid-1990s, people were talking about 3 transfers of 3 in some manuscripts. By the 2000s, 3 transfers of 2. And I think now we have, as things have improved, as we've gained insights from PGT, as we've gained insights from understanding the window of implantation, the way it shifts from classic studies by Ernesto Bosch and Shapiro and others, many others. I think that it's an exciting time, and now we can probably say that even failing 3 single embryo transfers, it really makes you an outlier, and we have to be concerned for this recurrent implantation failure diagnosis. Whether it should be modified if all the embryos are from just 1 cycle, for instance, not yet really studied or known, or whether or not that number holds up if it takes you 3 cycles to get there, or if you made 8 blasts, but 7 of them are aneuploid, are all factors which remain to be elucidated in greater detail. But today's papers, I think, are very exciting and move us forward in this understanding, which will ultimately end up with this recalcitrant group of patients. They're clearly there at some level. Prevalence is much lower than we used to think. And basically, hopefully this discussion today will lead us to a greater understanding of how to identify those patients, how do we evaluate them when we find them, and of course, what's the best way to treat them moving forward. So with that, I will turn over the microphone and we can begin the program. I'm excited and look forward.
Thank you, Dr. Scott. I think that it perfectly sets the scene for our paper presentations. The first one is going to be presented by Dr. Paul Purtea from the Division of Reproductive Endocrinology and Infertility at Hôpital Foch in Paris, who worked as a research fellow at RMA New Jersey during his study. His is a study that has received a lot of attention since it was published, and it is titled Rate of True Recurrent Implantation Failure is Low, Results of 3 Successive Frozen Euploid Single Embryo Transfers. And it was published in Fertility and Sterility just a couple months ago in January. Dr. Purtea, go ahead.
Hello to everyone. First of all, I would like to thank you. I'm extremely honored to have this opportunity to share with you some of my work. And also, I have been extremely lucky to have had the chance to work with Dr. Scott and his team. So my paper actually originated in a discussion from Professor De Ziegler with Dr. Scott in Barcelona during an ESHRE meeting, where actually Dominic asked Dr. Scott about what happens after 3 euploid embryo transfers. So I prepared some slides because maybe some data can be extremely complicated. Also I will present to you all the authors that have participated in this. So I hope the slides are okay. So this is the title, the rate of true recurrent implantation failure, which we consider to be low. And actually, we looked at the results of 3 successive frozen euploid single embryo transfers. So, as you know, as Dr. Scott mentioned earlier, there is no true definition for recurrent implantation failure. We might think that with IVF, all embryo that are transferred would actually implant in the uterus, but you know, beyond the clinical and biological, the less than 100% outcomes of ART also stem from the inherent limitation of human reproduction. So logically, those natural limits of human reproduction apply to ART as well. And although, let's say, ART may slightly outperform natural conception, courtesy of multiple ovulation and various methods of embryo selection, it still remains limited by the inherent poor efficacy of human reproduction. So several authors, starting in 2000 and up to 2014, have hypothesized and showed that when implantation failure occurs repeatedly 3 times or more, the condition is known to be this implantation failure. So when we talk about potential causes, I think that when we talk about, let's say, the morphological normal uterus, because in our study, we only took into consideration those patients with normal morphological uterus as verified by ultrasound and hysteroscopy. Implantation failure could result from factors that affect either embryo competence or endometrial functions. So numerous authors have claimed that the functional alteration of the normal uterus in otherwise morphological the normal endometrium in an otherwise not morphological uterus can hamper the capacity to implant. So the range of functional alteration proposed for explaining implantation failure include the window of endometrial receptivity. Then you have the endometriosis-associated endometrial impairments of receptivity linked to the BCL6 expression. And also you have all the immunological factors and not only the endometrial killer lymphocells. But when we talk about live births in, let's say, PGTA screen embryo, so PGTA allows for the transfer of normal chromosomal euploid embryos, and therefore PGTA excludes those embryos with a genetic composition that abnormal and thus prone to either not implant or cause miscarriage. So if you take live birth rates following euploid embryo transfer, the reported range goes from 43 to 77%. So you have great data reported by authors like Scott, Foreman, Capalbo, and Dahoud showing this data. But yet, as you can see, following PGTA, not all euploid embryos implant. And this is where the question lies, is what caused this implantation failure and possible recurrent implantation failure in particular. So then there is a theory that probably this could be to persistent endometrial causes. And this is why we, in our study, try to determine the true prevalence of recurrent implantation failure in women undergoing 3 successive frozen euploid single embryo transfers. So we did this with the help of Dr. Scott. We did a retrospective core study taking patients from 2006 to 2018. We did it in RMA, New Jersey. We had the PGTA platforms, and we only used frozen single euploid embryo transfer. So in total, we had actually 4,429 patients. We excluded all egg donors, gestational carriers, monogenic disease, and all those patients with an endometrial thickness of less than 7 millimeters. And we included mostly all those patients with a morphological normal uterus. So when you talk about results, it's very important to say that when we actually perform the first embryo transfer, we have seen that 69.9% of those patients obtain an implantation. So those 30% of the patient that didn't succeed, well, we have 571 patients who dropped out for different reasons like financial, emotional, and so forth. And we had 519 patients who still had remaining embryos, and 245 patients who needed to do another ART treatment in order to obtain new euploid embryos. So those patients who performed a second embryo transfer, actually 59.8% obtained a new implantation. So with this in mind, we see that 40 still left with no success. We still, in this population, had patients who have dropped out, actually 176. And we had patients who still had remaining embryos, and also patients who did a new ART treatment, as shown here, 39 of those. So this patient, when they performed the third embryo transfer, 60.3% of them obtained an implantation rate. Remaining only 52 patients, representing 39% with no success. When we look at live birth, we can see that you have the same kind of results, 64.8% for live birth after the first embryo transfer, 54.4% after the second one, and 54.1% after the third one. So this has pushed us to see that if we would do a cumulative implantation rate after the third embryo transfer, single frozen euploid embryo transfer, 95.2% of those patients would have achieved an implantation. And if we look at clinical live birth, we have 92.6% that had obtained a live birth, which was quite impressive for us. So certainly, when we, you might say that the implantation rate decreased from 69.9% to 59.8% following the first failed implantation of a euploid embryo. This quite indicate that probably the failed implantation following those does not really select out women with an overt receptivity disorder. And indeed, when we consider the first embryo transfer and the second one, when we have around the data, we show that there was no real difference between them. So when we talk about miscarriage, it's very important to say that the rate after positive fetal cardiac activity was 7.2% after the first embryo transfer, was 8.3% after the second one, and 12.7% after the third one. So when we compare the miscarriage results between after the first, the second, and the third, no real significance was found or observed according to our logistic regression when it was adjusted for age, as the P shown here. So certainly for discussions, we might, with our data that we have obtained, we can say that women who fail to implant following a course of frozen euploid single embryo transfer do not have a marked increased incidence of failing again to implant in the subsequent second and the third frozen embryo transfer. So we can strongly say that recurrent implantation rates following 3 successive frozen euploid single embryo transfer has an incidence of less than 5%. And this quite put into question the original, actually the original cause, whether it's the embryo or the uterus. And our data suggests that implantation failure of uterine origin are rare when euploid embryos are transferred in a woman with a morphological normal uterus. Certainly, our study has some limitations, as all retrospective studies. Certainly, some successive frozen euploid single embryo transfer came from different ART cycles. But when we have analyzed our data, we have, and we calculated the implantation rate of those two subgroups, those who had remaining embryos and those who had performed a new ART treatment to obtain new embryos. We have seen that the results are similar. Actually, it's 59.2% for those using remaining embryos and 61.2% for those who used embryos for new ART. As on the positive side, it's a very large size cohort, and certainly, as I said before, the implantation rates are similar in those subgroups that have done a new treatment. And I think that given the large of our cohort and our results, we can, being probably the largest reported of sequential frozen euploid single embryo transfer, we can reliably call into question the role of the uterine factors in recurrent implantation failure. As conclusion, our findings suggest that true endometrial recurrent implantation failure is rare when euploid embryos are transferred. I think, so in patients who have euploid blastocysts, 95.2% achieve clinical pregnancy after 3 frozen euploid single embryo transfers. And we believe that implantation rates decline minimally with increasing transfers, and additional euploid embryo transfer offer hope for a good outcome. Thank you.
Thank you, Dr. Pertea. What a contribution to the literature. Now, for our second paper, Dr. Mauro Cozzolino is going to be presenting another very interesting publication on potential evaluation and management of recurrent implantation failure. Dr. Cozzolino is a physician scientist at EV Foundation, and he's currently a visiting research scientist as well at Yale University. His paper is titled Evaluation of the Endometrial Receptivity Assay and the Preimplantation Genetic Test for Aneuploidy in Overcoming Recurrent Implantation Failure, and it was published in the Journal of Assisted Reproduction and Genetics in September of 2020. Dr. Cozzolino, please go ahead.
Hello again, everyone. I'm trying to share my screen. Okay.
There you go.
So, thank you. First of all, I would like to thank the organizer for the opportunity to present our data to this journal club. It is an honor and pleasure for me. So, as been introduced by Dr. Scott, recurrent implantation failure is still unsolved problem and is an important with clinical relevant entity. However, there is no consensus about the definition of RAF. Many investigators use the number of good quality embryos transferred or the number of embryo transferred to define RAF. For example, Coughlin et al. Suggested at least 4 good quality embryos based on the morphological assessment in a minimum of 3 fresh or frozen embryo transfer in women that are younger of 14 years old. So for sure, endometrium and embryo are the principal determinant of the implantation. Patients with recurrent implantation failure could have an increased risk of aneuploidy, and for this reason, PGTA should be considered in women with RAF. On the other hand, endometrial receptivity is also important, and several studies have suggested the possibility that endometrial receptivity is altered in patients with RAF. So, ERA test has been proposed as being able to detect the temporal displacement of the windows of implantation. And for this reason, in the last years, the ERA test has been used in women with RAF to determine the timing of embryo transfer with the adjustment of progesterone administration. So the aim of our study was to assess the effectiveness of PGTA and the ERA test in improving clinical outcomes in patients with recurrent implantation failure. This is a retrospective study. Our population was divided in two groups according to the number of embryos transferred. So the first group was moderate RAF with 3 or 4 embryo transferred, and the other group was severe RAF with 5 or more embryo transferred. In each group, we have 4 subgroups that were control, PGTA, ERA, and ERA plus PGTA. So the inclusion criteria were age between 18 to 45 years old, at least 3 failed embryo transfer in frozen or fresh cycles, and transfer of good quality embryo or blastocyst. Exclusion criteria were abnormal karyotype, congenital or acquired thrombophilia, endocrine and metabolic disease, atrophic endometrium, and submucosal myoma or polyps without previous surgical correction. So as we expected for the retrospective nature of our study, there were some statistical difference in the descriptive variables across the group. In the moderate RIF, patients in the control group were younger than those in the other group, while in the severe RAF, patients in the control group and in the ERA were older. Also, in a moderate RAF, patients, the mean number of previous fresh and frozen embryo transfer were lower in the control group, and similarly, in severe RAF, the mean number of previous frozen embryo transferred was lower in the control group. So in total, in our study were included 2,110 in the moderate RAF and 488 in severe RAF. So it's important that in severe RAF, due to the strict inclusion criteria, there were a lower number of embryo transfer in the PGTA group, only 72, and in ERA, only 35, and in ERA plus PGTA, only 6. As expected, the mean number of embryo available for embryo transfer was lower in the group of PGTA and ERA plus PGTA. And importantly, I want to highlight that the percentage of donor cycles was either in the control and the ERA group, both for moderate RAF and severe RAF. Regarding the result of the ERA test, as shown in the upper of the table, ERA test revealed non-receptive result in 14% of patients with moderate RAF and 25% of severe RAF patients. This is consistent with previous data of the literature that report the recurrence of non-receptive to the ERA around 14–25%. While, as shown in the upper of the table, the percentage of ongoing pregnancy rate in the patient that received PGTA was 10 points higher in the moderate RAF compared to the other groups. While in the outcome of ongoing pregnancy rate was not different in a severe RAF. So the univariate analysis demonstrates clearly that patients who received PGTA had a better odds ratio for implantation rate for patient and transfer and ongoing pregnancy rate compared to the control group, while there was no difference for ERA and ERA plus PGTA. In the severe RAF, there were statistically different across the groups. So considering that the retrospective nature of the study and the difference in any descriptive variables, we performed the multivariate analysis adjusting for possible confounder, such as the proportion of embryo transfer that used donate oocyte, the day of embryo transfer, the number of embryo transferred, fresh or frozen embryo transfer, and the mean prior number of embryo transferred in the previous cycles. So, and again, the multivariate analysis demonstrates clearly that patients in the moderate RAF that received PGTA have a better implantation rate for transfer and for patient and ongoing pregnancy rate compared to the control group, while there was no statistical difference for ERA and ERA plus PGTA. In the severe RIF, there were any statistically significant difference across the group. So our study for sure have any limitation, and the first one is the retrospective nature of the study, and the second one is the limited number of transfer included in the severe RAF that make difficult the conclusion about this group. So in conclusion, PGTA is associated with improved outcomes in patients with RAF, and the current test to assess the endometrial receptivity gives no clinical benefit in women with RAF. Thank you.
Thank you, Dr. Cozzolino. Let me try to share that. There you go. Perfect. That's a very, very interesting study, I think, on the role of PGTA and ERA for recurrent implantation failure. And I would like to move on to the discussion. And for that, I'm going to hand it over to Dr. Juan Antonio Garcia Velasco, who's the director of IVI Madrid and professor at the Rey Juan Carlos University. Dr. Garcia Velasco, whenever you're ready.
Thank you very much, Andres. It's a pleasure to be with you today and with this expert panel of authors and researchers. And I think we're listening to amazing data that is going to help us improve the care we provide to our patients. So before I introduce our discussants, I'd like to remind the audience to please type in their questions. This could be directed at the presenters, or they could be general questions for the panel. We have with us people that you all know, I'm sure. Of course, Dr. Richard Scott, who's been doing the introduction and is co-author of this paper, as well as Dr. Dominique de Ziegler from Hôpital Foch Hospital in Paris, co-author of the Pirtea paper and extensive experience in IVF. We have also Dr. Steve Young from the University of North Carolina, and he's been doing research in the implantation area for 20, 30 years, and also Dr. Nicolás Garrido from IVI Foundation. So we have quite a few questions from the audience, and before we start, I'd like to ask you a question that I think it's involves all of you, and we can start going around or as you wish. Because I think the data that Paul mentioned, Dr. Pirtea showed, is really amazing. And we see that with 3 embryos, we can have a clear picture of what are the chances of our patients of having a baby. But do any of you think that we could do better than that in the first attempt? We see that we have a 60, 70% chances in the first embryo transfer. And if we continue, we can add up to this. But do you think there is any role for, or any ideas that we could do better than that before we start?
I'll just throw out a brief answer to that. I'm very interested in everyone else's impression, but the answer has to be yes, Dr. Garcia Velasco. We have to be able to do better, right? So clearly, 40 or 45% of embryos, depending on which cycle and whatever, are not resulting in delivery, which means either the endometrium is failing, which we don't have as much evidence for, or and that really comes from the twin pregnancies where you get spontaneous reduction of one, not the other. So it's, which fails at about the same rate. So quite frankly, we just have to be able to do a better job. So I think there's a lot of assessment of the embryo, far beyond just conventional whole chromosomal aneuploidy, which is going to create a great deal of excitement in the next 1 to 10 years as we resolve this. But there's no question that many opportunities remain.
Any other comments? I'm sure. Thank you, Dr. Scott.
I have to agree with Dr. Scott, as usual. I think that it's not, we put an embryo in properly into the uterus. We shouldn't expect perhaps 100%, but we ought to do better than 50% implantation if we knew all the factors that were involved. I tend to think that, that we think of things in dichotomized ways. That is it the embryo or is it the mom? Or in this case, mostly the endometrium, but there are probably other factors. But they probably cooperate with each other. And that conversation between the embryo and the uterus might be very important for optimizing the first and second and third transfer. It's just that we don't understand it very well. And when we look at, oh, we got 60% implantation rate, I would note it was much lower in the other study, in Morrow's study. But we get 60% implantation rate. Some of that may be in bad endometrium, or some of that may be in marginal embryos. We do get loss rates, which trended up as we went on. And that has to be part of the continuum of implantation, whether it be good or bad. So those are my thoughts.
Thank you, Jan. I think this is what we have been seeing in the last few years, that I think this is not a balance between the endometrium and the embryo. I think it's an unbalanced equilibrium. I think that the embryo is weighting much more than the endometrium, and that's what it looks like. There's some question. Please go ahead.
Make a comment. I think we are at the core of our problems when we do IVF. Why does it not work all the time, as Richard said, even with the euploid embryos? And the core of the question, is it the egg or is it the chicken? In this case, the endometrium. Now, my reading of the information provided by Paul's paper when he was with Rich is that there does not seem to be women whose receptivity is lastingly disturbed. There are no women who appear to not be responsive at one point. The transfer of euploid blastocyst and the failure of that does not select out women who have a problem. Now, there are two caveats in that. The first one is that, as Paul said, they selected endometrium that were morphologically normal. And they were probably pretty good at doing that with hysteroscopy and ultrasound. And the second caveat, which I think is important, is that we're talking about blastocyst transfer in estradiol and progesterone cycles. Because in this case, the ovaries are suppressed. And we probably correct some of the problems that exist, for example, in endometriosis. In endometriosis, if you shut down the ovaries, the disorders that have been described by Bruce Lacey and others are corrected. So, but in that context, what is fantastic, we don't have women who appear to have a lasting and persistent endometrial receptivity problem. And we could have thought of that when you come to think of it. Because when we've done donor egg IVF, one who has done more than others is you, Juanita. Or when we've done donor egg IVF, we realize that there is line in receptivity. If you're careful to avoid fibroids and everything. And therefore, how could it be that some women would not be receptive and others would be, and that there would be no deterioration of this problem with age. A woman of 50 years old is just as receptive as a younger one. So I think that the information that Paul's paper is very, very, very dramatic. There is no alteration of the endometrial changes that lead to receptivity. In a lasting form. It could be that in a random form, some women on one day are not receptive and they will be receptive next time. But there is no selection of women who were not receptive. So very, very good piece of information, very important paper. Congratulations to Paul and Rich.
So Dr. de Ziegler, I have to agree with you on most of that, but Paul, your paper shows, Paul, your paper shows, they had such a high dropout rate, right? And so we could probably have a wider range of implantation that wasn't captured. I don't know why they dropped out, but one assumes that some of them were very poor prognosis for one reason or another. And I wonder, were there any procedures? Was there any surgery? Was there anything else done between cycles that might have improved things for the patients? And I think we also have to remember that the receptivity dropped from first cycle with a euploid embryo to the second cycle. Perhaps it's just one euploid embryo now that helps us determine who's at best receptivity.
Well, thank you for that question. Actually, I think that our study shows and reflects the image of a real IVF center where you have patients that drop out with multiple reasons, and the price of care is very high these days, and notably in ART. So probably in those patients that dropped out, you'll have a certain population with a poor prognosis, but probably you have also just normal patients who didn't have enough oocytes or the chance to have a euploid embryo, because we can see that today that there are some patients that do not have euploid embryos, and probably other IVF cycles will bring euploid embryos. So to regard with that, as you see, some drop out, but some also need to perform a new IVF cycle. So this is why we looked at the data to see, and those two subgroups of those who had euploid embryos, remaining euploid embryos, and those who needed a new IVF cycle had actually obtained the same implantation rates, similar actually.
Sure.
So
if I can add to that, Paul, a couple of comments. One, the dropout rate is very much keeping with the dropout rate that has occurred in German studies and Scandinavian studies, where the patients were young, good prognosis, and had access to free care through the social healthcare system. So I don't know how many of those would have been discouraged from trying again from a single cycle. Certainly it had to have been some, but I don't believe it was many. We don't really do, if someone's got an abnormality, we correct it before their first cycle. We don't do a lot of adjunctive surgery. So I would imagine that number is extremely low. And I'm smiling only because Dr. Young and I have been back and forth on this many times over the years, but he says that there's a reduction in receptivity in the second cycle. And I would say, we don't know that. Only the reduction in sustained implantation rates. It may have been wholly on the embryo.
Absolutely.
Because we do have less opportunity for selection. These are less morphologically ideal embryos because we didn't pick them first. I suspect it's a mix of both, if I had to give my honest guess. But of course, that remains a topic for future investigation.
Yeah, so we assume that those 10% drop from the first one for the second and the third one could be actually due to morphology selection. But as you see, the third one, which you still have a very complicated population, still have 60% chances of implantation and also more or less the same chances of live birth. So there is no increase in miscarriage, and there is no real decrease in chances. So, yeah, I mean.
So, Paul, can I make you a question?
Yes.
Okay.
Yes.
So I'm curious concerning the pregnancy rates per embryo transfer that you were showing. As you recently said, it comes from almost 69, something like that, to 60, and then 60 again. And I have a question that probably you or maybe Dr. Scott can answer, which regards, do you have any information about patients undergoing the fourth cycle? Because without PGPA analysis, it's my understanding that the rates are decreasing the more failed transfer that you accumulate. But in this case, this seems to be very stable through the cycle. And this can point to more related embryo quality issues instead of endometrial issues. So the main question is, do you have any info about the expected pregnancy rates in the fourth cycle if they stay the same levels?
So regarding the fourth embryo transfer, I will leave Dr. Scott because my time in New Jersey was ended by, so I'm back in Paris and I cannot answer that question, but I'm sure Richard is going to be happy to.
We have done some follow-up on Dr. Patea's data, which again came out of an idea that Dom had at Escher some years ago. It has just been really a very fun data set. But the reality is we went back and looked at those people who failed the third cycle. The number of transfers, I apologize for not the exact number, but it was a little under 40. Many of those patients did have to do an additional cycle. So I want to qualify that. But within that group, the clinical pregnancy rate was about 62%, and the ongoing rate was about 52 or 53%. So the loss risk did appear a little higher, but the overall rate, I would say, is plateaued still. And so even with the fourth cycle, that drives the cumulative delivery rate up to 95 or 6, and the cumulative clinical rate up to 97 or 8, about 95 and 98. So the fourth cycle did well, and we don't really have fifth cycle data today.
But don't you think this is just pointing that the embryo trouble is solved with PGPA and probably there's an underlying endometrial factor that probably varies from cycle to cycle?
I'm going to weigh in, and then I'm definitely going to want everyone else's opinion, but I think for sure there's some people with endometrial receptivity disorders in here. And that impaired receptivity is definitely part of this story, no question. But the single greatest variable that changed between those cycles is that it's a different embryo. Because, well, it is a different endometrium, that variability is likely lesser. And so I still think what you're seeing is the fact that different embryos have different reproductive potentials. And in some people that's impaired, and you're just finding the right embryo. So I think there's likely to be a substantial component of both of these, but I wouldn't ignore that just because we have a morphologically normal, or if you're doing time-lapse typically normal euploid blast, there's tons of other things wrong with those embryos that we're just not identifying reliably yet.
I agree. But my point was in comparison with those non-PGPA cycles, where you can see that patients' chances involve lower pregnancy rates per transfer as you accumulate failures. So it's not the same ratio in the first cycle, the second, the third, the fourth, and it drops down. But in this case, what is surprising for me is that, exactly.
Yeah, but this is, I think, is a very interesting message, what Dr. Scott just mentioned, because we can use this extremely well with our patients. Many times, I'm sure we'll get a question from our patients, but doctor, if you're going to do the same thing and you're going to repeat the cycle the same, you're going to have the same outcomes. Absolutely not, because you have a completely different embryo. The rest of the things are fine.
I think it is the cumulative perspective.
Right. I have some questions coming from the audience, and these are mainly, I think, for Paul, because they're asking, why did you exclude donor data? Would you expect different outcome, or maybe for Dr. Scott as well? And why not include a group with time-lapse with no PGTA?
So about the donor, I mean, we wanted to have real IVF couples, because if you include donor, then you can expect that the embryo will be just great and will just hide out those who can have a real problem of infertility. Because we all know that in donor cycles, you have superior outcomes. in mostly for those with probably recurrent implantation failure due to embryo lack of competence. So we didn't want to select out and maybe hide those patients. We really wanted to address couples that have the possibility to obtain oocytes and spermatozoid in order to get an embryo. So we didn't want to bias our study with those donor egg cycles. I don't know if Richard agrees with me, but
I certainly agree. We wanted to see the negative effect of both embryonic and in vitro factors. Obviously we didn't really distinguish them in the study, but we did want to see the cumulative effect, and for that, donors are not the ideal. What was the other question, Juan? I apologize.
They were asking about adding a group with time lapse with no PETA, if this would be representative of real life data.
Well, our experience is that we have not had seen significant improvements in implantation rates with time lapse. I know others have different experiences, and I'm respectful of that, but we have not, and so we don't use it routinely. So we would have nowhere near enough data from routine patients, routine clinical care, to make that type of assessment. Perhaps centers that do both well, and I think you would need to do both well. David Cram's data would suggest that from China, et cetera. Could potentially answer that question for us in the future. It's still about identifying that, ideal embryo and that ideal endometrium, and there's work to be done.
And I'd like to ask a question to the panel. What do you think of the concept of I think this is Macklon's speculation about the permissive endometrium or the restrictive endometrium? Do you think this may make a difference?
I might make a comment on this just for just a second. I think what Macklon is saying is that the good embryo is actually acting on the endometrium and selecting changes occurring in the endometrium. In essence, all that we have seen in that study is perfectly compatible with what Nick is saying in terms of receptive endometrium and selective endometrium. If we were able to actually assess the endometrium on the day of the transfer, which one day we might do, then we might find some alteration that would be actually a specific reflector, if what Nick is saying is right, specific reflector of the quality of the embryo.
I just want to add that, and then I do Steve's comment, but I agree with Dom completely. This communication, Paco Dominguez from our group has contributed to studies in this area. Diego Marin has worked on it. Right now, it's really difficult to look at extracellular vesicles, look mechanistically at some of the factors that may be involved in communication. But those technologies are going to improve, and we're going to get better at evaluating those things. And then I think that's where we're going to open a huge door that may give you an integrated effect of an embryo and the endometrium. But Dr. Young, what's your impression?
Exactly what I was going to say, and what Dom said, that it's a conversation, and you can have a lousy endometrium and a really good embryo, and you might get pregnant at some reasonable rate. And you can have a lousy embryo and an excellent endometrium, and you might get pregnant, although you'll probably lose it at some reasonable rate. And so this is not a dichotomized thing. And if we're going to get to 90% in one cycle, we're going to have to pay attention to both separate factors and the combination.
Thank you. I'm thinking also from the pragmatic point of view. We are here identifying recurrent implantation failure by deselecting patients that already got pregnant. How do you think we can put this the other way around? How can we identify patients, that 5% of patients that will not make it in 3 embryo transfers? Is there any way we can identify or pre-select these potential difficult patients?
I'm not sure we can do that, but we should try to find a way, but I'm honestly, I have no clue how.
I believe that the studies like Dr. Pertea's and the work of Dr. Young and Dr. Ziegler and Nestor Bosch and many others are going to teach us, because we're going to identify these subsets of patients. Then we're going to learn what's going on that makes for these patients to have lower implantation rates and recurrent failure. And then there'll be another opportunity to study to see, hey, if we study this prospectively in the general population, are there going to be too many false positives, or is this finding going to be specific enough to provide predictive values, which means we should screen everybody and we'll get faster to that 90% margin with Steve. So I think these are the kinds of studies you're going to need to really identify meaningful, impactful factors which are limiting outcomes. Then we can do the prospective studies on a broader population to see if the predictive values are there or if the false positives are too detrimental. Steve?
Got nothing to add to that. You know, there's a lot of small studies, like Bruce Leslie has a nice one of BCL6 that we've worked together on that suggests you can predict, at least in a subset of infertility patients, IVF success somewhat by looking at BCL6, but that's very preliminary. There's a much larger study going on right now at Stanford to see if that's indeed true. But I'm curious, so Dr. Cozzolino, is it true that in your population that you looked at, there was those with severe recurrent implantation failure had about a 36% implantation rate? If that's true, if I read it correctly, that's much lower than Dr. Pertea's study. You know, and looking at those differences in implantation rate may lead us to some factors, right?
Sorry,
No.
Dr. Cozzolino, I think you're muted still. If you can turn on your sound.
Yes, was lower. So I don't know if maybe in our study we included patient with worst prognosis. So it should be a reason that we have lower implantation rate. But also in the group of severe RAF, we have not too much embryo transfer in the control study. So honestly, we can have a good conclusion for this group.
But even in the PGTA treated ones, even in you had quite a low implantation rate in comparison to Pertea's study, right?
Yeah.
Why?
So, so you are meaning why was lower for the PGTA? So maybe we can't exclude it. So that when we decided this study, the major idea that we have behind was that okay, let's try to divide for the number of the embryos, and let's to understand if different tests could be useful for different situations. So we hypothesized that for patients that have more embryos, more of 5 embryo transfer failed, PGTA is not enough alone to improve the clinical outcome of this patient. But at the end, for the number of the embryo transfer that we have included, we can conclude this. So I don't know if Nico wants to add something.
Yeah, I would like to jump in. So I think the answer for Dr. Young is that there's a big difference between the two studies. Pertea's study included patients up to 3 embryo transfers. We included patients from 3 failed embryo transfers. So populations are completely different. This is the main reason.
Yes, but doesn't that then provide you with the basis for preliminarily for a definition of recurrent implantation failure? Those are the patients that are affected. It takes multiple failures. And you've now identified a population which is not as benefited by PGT as the population in Pertea's study. That's my question.
Yeah, you're right. Probably these are the more recalcitrant patients. So those that have failed multiple occasions and probably the worst case.
I might have to take exception to that. You can't compare those data to the New Jersey data and say that definified that group. You'd have to compare it to the first 3 cycles in those. to reach that conclusion. So actually those data cannot be compared that way, and I don't believe they yet. They might if analysis.
That's why I said preliminarily.
But well, I would say you can't even do that analysis. I would say that's not a preliminary finding. It's not.
Well, Richard, why was implantation so much lower?
Well, why is it different in all programs? Why is it different in all programs? So I think every
good question.
Sort of its own control, and there are many answers to that, and we know some, but not all of them, for sure. And so I think in these types of study, you want to hold as many variables constant as you can, and the nature of the laboratory, the transfers, the clinicians, the timing, the patient selection, all of those things should be held constant. So I would be very hesitant to compare data between studies, to reach too many conclusions one way or the other. You would have to look back within those same programs to look at their initial 3 cycles and their implantation rates to see if there's a difference.
I would like to ask a question to Rich, if I may, because I'm really curious about the answer. What the study has shown is that not just the implantation rates, but the failure rate remains constant for the euploid embryo transfer. And therefore, my question is, do you have any idea, any speculation as to what mechanism would be responsible for the embryo not to implant? You might have looked at the preprint by Screwcraft's group on possible epigenetic alteration of the uterus. You want to speculate on that? I was so interested in knowing your thoughts.
Well, I think one of the questions I saw in the Q&A addressed some of those issues, and it's very interesting. So I think subchromosomal defects, and particularly in terms of segmental abnormalities, are going to be very important here. The non-selection data, but we only screen about 5% of the genome when we do PGT accurately. And we're still finding a significant number of segmentals, and they have about a 50% reduction in implantation rates. If we could screen more comprehensively, we'd likely find more, and it might be impactful. Those are all mights. I have no data. Please don't consider those evidence-based in any way. And similarly, I think you're going to find from Dr. Young, like Leslie's work, others, that some people are really going to have impaired endometrium, and still another group is going to have an impaired communication crosstalk conversation that Dr. Young is talking about. So I think we're going to find all of those. But I still think, if I had to guess, that the biggest chunk is in the embryo. It's not mitochondrial DNA copy number. We know it's not that. It's not basic timing issues once you control for synchronizing with the window of implantation. It's going to be more complex than that. But it could be mitochondrial function. I think it could be very, very important, which is not copies of mitochondria, but how they're performing. And I think segmentals, and I think all the work that Steve has done is stating, and we'll also find a way into this story. So who knows? That's why we're all so busy doing our studies and answering questions.
We might also make a comment on the type of treatment for transferring frozen embryos. I mean, you have used what most of us have used, the estradiol and progesterone cycle. As we all know, there are now discussions and questions about the value of the natural cycle transfer, because in the natural cycle you have relaxin. But what I think we might emphasize and underscore here is that actually there might be some differences in terms of obstetrical outcome and in terms of preeclampsia, and that's a different topic altogether. But the estradiol and progesterone cycle is still giving an unsurpassed receptivity in terms of priming the endometrium. Do you agree, Rich?
I would love Dr. Young's comment on that, but I still do think that that's true, that we really haven't beat the gold standard. Dr. Gerson Weiss will undoubtedly appreciate you mentioning relaxin. I know you spent some time with them in Newark, but there likely are factors there. I just don't know that we know what they are, and they may be important. But right for now, anyway, the gold standard still remains estrogen and progesterone, timing the window in a conventional sense, because the other things really have not consistently been able to be demonstrated to be useful. Dr. Young?
I think it's important to underscore that for the people who actually are listening to this. Dr. Young, what are your thoughts?
Best I can tell, there are no data that show anything better than estrogen and progesterone. I think that's what Richard said. And however, there are some preclinical data, I guess I would say, that there is a difference, and relaxin, apparently may be one of the culprits in the increased rate of preeclampsia in those kind of cycles, in estrogen progesterone cycles where you suppress completely the formation of corpus luteum. And it's no doubt that the corpus luteum is making a bunch of hormones and that they may have some modulatory role. But if we give enough estrogen and progesterone, we can, in the vast majority of patients, overcome any deficiency that we're not giving from the corpus luteum, or those other factors are simply there because of evolutionary reasons and not for function, which hard to imagine, but it's possible. So I agree with both of you. However, anecdotally, the problem with anecdotal information in this area is that people do well in the next cycle, as Dr. Pertea just demonstrated quite nicely. And so, when I take a patient and put her on a modified natural cycle because we had troubles, and she does well, then she thinks I'm a genius. And then I get a big head and I feel really good, and everything's great. But and then I think, oh my gosh, I am such a genius. I'm going to put everybody on there, and that's a bad way of practicing, I think. And so I have to agree with both of everyone has said that estrogen and progesterone is the standard, and we don't have any good evidence anything else is better in regards to live birth.
Thank you. Let me ask you a final question that could take us another half an hour or so, but let's try to be brief and just trying to identify where to put the balance in the embryo endometrium again. I mean, the value of PGTA on embryo selection is undisputable for sure, but what about biochemicals? What about when you have a biochemical pregnancy? Maybe here there is a bigger role for the endometrium. What do you think?
Steve, why don't you go first, and I'll follow you this time.
I think we don't know what causes biochemicals, and so it's whenever we don't know something, we always like to say it's the endometrium. At least I do. What I would say is that using PGTA, to my knowledge, has never shown a decrease in biochemical pregnancy rate, and thus whatever it is is causing biochemicals is not related to whole chromosome defects. And so is it an embryo? Is it endometrium? Is it both? I don't know the answer, but Bruce has a handful of patients with BCL6 overexpression and SIRT1 overexpression that suggest that those patients have an increased rate of biochemical pregnancy loss, but those are very small numbers, and I don't think we can take them to the clinic.
I couldn't agree more with Dr. Young. So we have many tens of thousands of transfers of data from PGTA over the years between the US and Spain. And I can tell you that the biochemical rate is not impacted by PGTA. And in fact, even without PGTA, the biochemical rate doesn't change with age. It's the same at 25 and 43. So, this is a different beast. This is a different problem, and it may be the endometrium. And so I think that very interestingly, some data that's been coming out more recently over the last several years, the hyperglycosylated HCD data showing that it's abnormal from the beginning. Again, it doesn't necessarily resolve this issue of embryo versus endometrium, but it certainly shows you that something is broken early, and it's not going to be as simple as aneuploidy. So obviously we're losing 8 to 10% of pregnancies if you look at all of infertility care to biochemical losses. So I sure hope Dr. Young figures it out quick and straightens this out, because this is a big burden clinically.
All right, so I think it's time to finish. Maybe Andres will take over from here.
Yes.
Thank you very much.
Absolutely. Thank you, Juan. Thank you, everybody. This was awesome.
Congratulations for this nice meeting. Very good.
Thank you.
Congratulations to the
Sharing.
authors.
Yeah, congratulations
Thank you
to both
for
the
your-
authors. It was great.
Thank you for inviting us.
Our pleasure.
And
Thank you.
I would personally like to thank Dr. Scott and Dr. De Ziegler, Professor De Ziegler, for the help that they provided for this paper. Inspiration is priceless. So, and I hope that the paper will probably help everyone to try to do the same treatment again and again for those patients to gain trust and eventually succeed.
Absolutely. Absolutely. Thank you. Thank you so much to all of you for participating today. Thank you to all the audience for joining us. I know there were some questions that we couldn't get to, but that's the nature of time constraints. If you want to listen to our past journal clubs or know anybody who wasn't able to join in today, as you know, all of our journal clubs are available on our FertiliPod podcast, on Apple Podcasts, Spotify, wherever you get your podcasts, and on our website as well. Thank you so much. See you next time.
Thank you.
Thank you.
you.
Thank
Bye.
you.
Take care.
Bye.